You guys will hear the recording. Okay. So a few housekeeping rules. We're using a Zoom platform tonight. So many of you, I think all of us are way too familiar using Zoom these days, but we do encourage you to follow good Zoom etiquette. So please try and keep your phones on mute and to not interrupt the program tonight. We will be obviously wanting to give you the opportunity to ask questions. We encourage you to use the chat feature as we go through the planned comments this evening, so your questions can be answered at the end of the program by Dr. Barratt. You do have myself and Valerie serving as co-hosts tonight. We'll be letting folks in and out of the waiting room. If you happen to drop off, we'll be able to let you back into tonight's program as well. I think, let me just double check there's no one else waiting in there. There's not. So what we're gonna do initially is I just need to thank Joanna Harrell, who is the thought leader liaison with Calliditas Therapeutics. She has been instrumental in helping us put together this program tonight for the FSN. This is a repeat of a couple years ago. I shouldn't say a repeat, it's an update from a couple years ago where we had Dr. Barratt join us previously. So we're happy for him to be back with us. And Joanna, you're instrumental in making this happen. So I want to give you an opportunity to say hello and introduce yourself.
Hello, everybody. My name is Joanna Lorenzo Harrell, and I am the thought leader liaison for the Southeast. And on behalf of Calliditas, I'd like to thank everybody for joining us tonight. And I'd also like to thank the Florida Society of Nephrology for allowing us to have this presentation. Thank you.
Terrific. Thank you very much for that, Joanna. And now it's my pleasure to introduce our main guest for tonight's program, Dr. Jonathan Barratt. Again, this is the second time he's been with the FSN, so we're pleased to welcome him back. He is the renal research group. He leads, the renal research group within the College of Life Sciences at the University of Leicester in the United Kingdom. His research is focused on a bench-to-bedside approach to improving our understanding of the pathogenesis of IgA nephropathy, a common global cause of kidney failure. He is also the IgA Nephropathy Rare Disease Group Lead for the UK National Registry of Rare Kidney Diseases, RaDaR, and a member of the steering committee of the International IgA Nephropathy Network. So again, we're so pleased to have Dr. Barratt back with us tonight. We look forward to his programs. Again, we encourage you to use the chat to ask questions as he goes throughout his presentation. And with that, Dr. Barratt, I will turn it over to you and let you begin your planned comments.
Yeah, thanks very much. It's great to be back. And ironically, I'm flying to Florida tomorrow for a meeting. So I will be in Florida in 24 hours time just for a short visit. But it's great to be asked back to give an update on where we are with IgA nephropathy in 2025. So here are some disclosures. This is a program sponsored by Calliditas, but I'm not going to be promoting Calliditas or their drug. And in fact, I'm not going to mention drug names for most of my talk. So this is meant to be a fair and balanced presentation. But of course, I'm willing to answer questions that you may have at the end on any particular drug. So please just pop questions in the chat. Here are my own disclosures in terms of funding conflicts. So let's get cracking. So IgA nephropathy is a relatively young glomerular disease. It was only described for the first time in 1968. So it is 57 years old this year, and it was described by a Parisian pathologist, Jean Berger, who gave his name to the disease originally. So it was originally called Berger's disease, but now is known as IgA nephropathy. And he was able to describe this disease because he got his hands on some antibodies that allowed him to stain kidney biopsies and identify mesangial IgA immune complex deposits in kidneys. And he related that deposition to the presence of blood and protein in the urine and a mesangial proliferative glomerulonephritis that commonly affected young adults, particularly young men. And at the time, it was thought that this was a benign disease that really didn't have significant implications for long-term kidney health. But what I'm going to show you really challenges that myth. Clearly, it's been around for a lot longer than 1968, and this is one of the oldest cases I can find. A very famous US naval admiral who is thought to be the father of the US Navy. He had his kidneys preserved in formaldehyde, these kidneys were then retrieved and subjected to modern technologies. And there's a very nice paper that describes that process and reports that he had IgA nephropathy as the cause of his kidney failure. So this disease has been around for a long time, unbeknownst to us, but in terms of as a recognized disease, it's been around since 1968. Now, as I say, it was first thought of as a benign disease, and actually was called benign hematuria. But what we know now is that this is the most common form of primary glomerulonephritis in the world. And it's estimated that 1 in 10 people who are on dialysis because of IgA nephropathy globally. Now, I doubt that's what you see in your practices in Florida. It's certainly not what I see in the UK. This is heavily driven by the incidence and severity of the disease in East and Southeast Asia. And just as an example of that, there are estimated to be more people on dialysis in China alone than in the whole of Europe. Unlike in Europe, 1 in 4 of those patients on dialysis in China is on dialysis because of IgA nephropathy. So that gives you an idea of the extent of the public health problem and the impact on chronic kidney disease and end-stage kidney disease that IgA nephropathy has globally, particularly, as I say, in East and Southeast Asia. And of course, patients from that part of the world bring that risk with them when they emigrate. And so when I look at my patients, the worst IgA nephropathy I see is in my South Asian population in Leicester. The worst IgA that colleagues in the US see is in their East Asian population and Southeast Asian population. So in their Philippine population, their Chinese, Japanese populations, and in their Hispanic populations. And we've now got some data from the US looking specifically at IgA nephropathy incidence and severity in Hispanics. Clearly, we can't comment on that in the UK because we have a very small Hispanic population. But it seems very clear that this increase in incidence and severity that you see in Eastern countries actually migrates with the person when they move into Western countries. They don't lose that risk. That risk is still inherently there. We also know that this disease recurs in kidney transplants. And that's one of the commonest things I get called about now, is how do I manage this young person who's already lost their 2 native kidneys and has lost their first graft and is on the way to losing their second graft? What can I do? Because this person is going to end up being untransplantable if they have significant panel reactive antibodies that mean they will not be able to receive a kidney. So that's a real issue for a proportion of patients with IgA nephropathy that are fortunate enough to get a kidney transplant. And I'll show you some data in terms of outcomes shortly, really stressing the importance that this disease carries a significant lifetime risk of kidney failure. If we look now at the proportion of patients that have the prevalence of IgA nephropathy in different parts of the world, you can see here the estimated number of people. But this is likely to be a massive underestimate. And the reason for that is you can only make a diagnosis with a kidney biopsy. And so the accessibility and affordability of a kidney biopsy varies greatly across the world. And I'm sure if I asked everyone on this call and gave you all a few clinical scenarios, would you do a kidney biopsy in this person? We will get different responses. And your threshold to perform a kidney biopsy will very much influence how much IgA nephropathy you see. If you have a very high threshold, you won't see very much IgA. If you have a much lower threshold and you biopsy people with low levels of proteinuria, you are likely to see far more IgA nephropathy. And what you'll see in the KDIGO update is that we are really promoting an early diagnosis of this disease so that we can institute treatments early while there are still nephrons to save, rather than making a diagnosis later when there's much more proteinuria, there's more advanced kidney failure, when we are dealing with a patient who has far fewer nephrons for us to be able to save with these new treatments. So I'm going to touch briefly on some data from the UK. You may have heard this before, but I think it's really important to really dispel those myths that IgA nephropathy is a benign disease that we don't really need to take very seriously. So this is data from the UK, so it reflects a UK population, so predominantly European ancestry. The next commonest population is us South Asians. It includes adults and children, and patients were recruited from every kidney unit in the United Kingdom, so from England, Scotland, Ireland, and Northern Ireland and Wales. And so what did we see when we just look at overall outcomes? And these are patients managed to standard of care at the time, which means blood pressure control, RAS inhibition. We don't use much steroid, and we don't use anything else in terms of immunosuppression very often in IgA nephropathy in the UK. And so what you can see here is that after 20 years from diagnosis, half the kids have developed kidney failure and 3/4 of the adults. So 20 years after a diagnosis for a child means we're talking typically about people in their mid-30s. 20 years after diagnosis in an adult, we're talking about people in their mid-50s. And you can see that here on the right-hand side, where I've put an upward arrow, which is someone in their mid-50s, so someone my age. If you're a child diagnosed between the ages of up to the age of 18, you can see here over 3/4 of those kids, by the time they're my age, will have developed kidney failure. If patients were diagnosed between the ages of 18 and 40, by the time they reach my age, 2/3 of those adults have developed kidney failure. And diagnosed between the ages of 40 and 50, half of those adults have developed kidney failure. So this is clearly not a benign disease according to these data. What we did as well was we simply took the GFR on the day of diagnosis, the day we as nephrologists get our hands on these patients and we know what's going on. And we said, okay, based on the age of the patient, what's the likelihood that they're going to develop kidney failure for different rates of loss of kidney function for the rest of their life? And so if we look here, if we just take these 18 to 30-year-olds, based on real data, kidney function on the day of kidney biopsy, if we see here a rate of loss of kidney function of 2 mils per minute per year for the rest of their life, 89% of those young adults will develop kidney failure in their lifetime. And this is not making any assumption about proteinuria. This is not making any assumption about what treatments they get. If we do not achieve 2 mils per minute per year, 89% are going to get kidney failure. If we get down to 1 mil per minute per year for the rest of their life, we halve that number and we get it down to 40%. But you still see that for an 18 to 30-year-old, even if we get to the physiological state, which is 1 mil per minute per year, 40% of those young adults will develop kidney failure in their lifetime. And that's because they're young, they need their kidneys for 50 years plus. But also, by the time we get our hands on them, they've already sustained significant nephron loss, because this is an asymptomatic disease that we normally diagnose completely by chance. So the typical GFR in the radar cohort and in the cohort generally in the UK, we pick up patients with a GFR between 50 and 60 mils per minute, which means by the time we get our hands on them, typically those patients have lost half their nephrons. So essentially they're coming to us with a single kidney and an active immunological disease. In the US, that GFR is about 10 to 15 mils lower. So there's a much later presentation. So you have an even harder job when you have a young adult presenting with a GFR in their 40s to try and keep them off dialysis in their lifetime with the treatments that have been available. It might be changing now, but we really do have our work cut out. So this really does reflect the seriousness and the speed at which we need to assess our patients and intervene. We don't have time to wait to give our patients treatment. We've got to save every single nephron they have left when they see us. And of course, when you look at this physiological state, 1 mil per minute per year, you can see that this is typically, the outcomes are similar across all the age groups at diagnosis. And of course, the degree of proteinuria will determine how quickly kidney failure is going to develop. And we've known this for many, many years. Multiple studies, including the Toronto Registry, have shown the higher level of proteinuria, the more rapid the loss of kidney function. If you look here, we measured proteinuria in 2 different ways. Those with more sustained proteinuria above 2 grams, if you look out here at 10 years, over 3/4 of those adults have developed kidney failure if you have proteinuria above 2 grams persistently. So that's kidney failure in the 40s. If you look, and we've always known that to be a high risk, but what we were able to show in the radar data, because of the amount of data we had, was that even at low levels of proteinuria, levels we traditionally thought were okay, there still is a significant risk of kidney failure in a proportion of patients. And so if you look here at these 2 lines at the top on the left-hand side, even below 1 gram or below 0.5 gram, at 10 years, roughly 1 in 4 of those patients has developed kidney failure. So 3 out of 4 haven't, but 1 in 4 have, which tells us that actually we need to be aiming for much more stringent proteinuria control to get anywhere close to preserving nephrons and preserving kidney function. And again, that's reflected in the KDIGO update, with a much lower threshold of proteinuria to trigger a biopsy, much lower level of proteinuria to say this patient is at risk of progression, and a much more stringent target to reduce proteinuria. Now, this people have thought was a quirk of living in the UK. So UK patients with IgA are different, and UK doctors don't know how to manage kidney disease. But I'm pleased to say that actually, or not pleased to say, but these data have been replicated in cohorts from China, from other European countries, from Canada, and from the United States. And actually outcomes are as bad, if not worse, in some of these studies. And I just want to point out the work that John Sim has done in California with the Kaiser Permanente data. And he's presented at the ASN. It's not published yet, but his outcomes are poor in his US cohort. And for the first time, he was able to show the impact of IgA nephropathy in a Hispanic population. And Hispanic patients have a high incidence of IgA nephropathy, consistent with the Chinese population, and as bad an outcome. So we just don't see that many Hispanic patients in the UK, but I would imagine in Florida, you see a fair few, and these will be an at-risk population for IgA nephropathy. And what we've done, and I've just seen some data today, is we've taken John's US data and we've overlaid it and matched it to the UK data to say, are these two populations behaving the same? Different healthcare systems, but we match them for year of diagnosis, baseline proteinuria and GFR. And we're going to be presenting that data in due course, just to see what the pattern is in different parts of the world, to see whether there are any differences or whether outcomes are equally bad everywhere. And so one of the things I really want you to take from this is when you're looking at that patient, particularly that young patient in your consulting room, is you must think about the lifetime risk of kidney failure. If they're in their 20s or 30s, not much may happen over the next 10 years. You know, it may just you may not see much difference, but you've got to remember those patients need their kidneys for 50 years. Or even longer. So we need to always be thinking about lifetime risk of kidney failure, because once nephrons are lost, we can't get them back. And so thinking down the line, oh, I wish I'd started something earlier, is not going to help the patient. And we need to think about saving every single nephron that patient has left, because when they come to us, they will already have lost a significant number, because this is traditionally a silent disease that is normally just diagnosed by chance because of a urine dip, a blood pressure check, or a blood test. And so when we're looking at that patient in our consulting room, we need to be thinking, okay, what's driving the nephron loss going forwards, and what can I intervene on? And they have two separate processes. They have the IgA nephropathy, the generation of immune complexes, their deposition, that driving of glomerular injury. So I need to think about how I'm going to approach that. And for many, many years, we had nothing to be able to manage that was safe and effective. But that's where things have changed. But I also need to accept that the patient that comes to me may well come to me with a GFR of 45. I'm going to have to accept I need to treat their general CKD with CKD treatments. Now, they're not going to treat the immune complex mediated glomerular disease, but that's not why you're using them. You're using them to manage those downstream consequences. And so you need to think about those two separate disease processes, and you need to address both of them, because by addressing only one, you are never going to get this disease under control. And of course, in this diagram, it's highly stylized, but you can imagine that if I were able to detect a person at the beginning of the disease, I wouldn't even think about CKD treatments because they've not had time to develop all that scarring and lose those nephrons. I would just purely concentrate on the immunology of IgA nephropathy. And that's what happens in countries where there are nationwide screening programs. So in Japan, South Korea, and Taiwan, they screen every school child every year with a dipstick. They pick up disease very early. At a time they pick it up, there's very little scarring, there's very little nephron loss, good GFR, and therefore they don't need to think about CKD treatments. They get on and treat the disease. Whereas for us, unfortunately, we have no choice but to think about the CKD treatments because our patients are presenting late. And as you can see here, they present late, which means our therapeutic window to address drivers of nephron loss is much more constrained, and we don't have time to wait to really keep that kidney function as stable for as long as possible. And so we had an update to the KDIGO guideline in 2021. This was a fair bit of work, and really what it showed us was that we hadn't moved forward in the 50 years that we'd known this disease. And so what you will see front and center was the only way we felt we were going to be able to address the kidney failure risk in IgA nephropathy was to promote the inclusion at every opportunity of patients in clinical trials, because that was the only way we were going to identify safe and effective treatments. And so you will see here in 2021, consider enrollment in a clinical trial was absolutely what we wanted people to think about first and foremost when they saw a patient with IgA nephropathy. The reason we did that was, as I said, we had no treatments. There had never been an interest in developing new therapies for IgA nephropathy because the approval pathway with the regulators was so difficult. And it was so difficult because if we use the traditional endpoint, which is a doubling of serum creatinine end-stage kidney disease or death, we would need thousands of IgA patients followed over years and years to ever know whether a drug worked, because it's a slowly progressive disease. And this was just felt to be too high risk, too expensive, and unachievable by pharmaceutical companies. And so people just didn't even think about studying IgA nephropathy or developing new treatments. But that all changed thanks to the FDA and the ASN. And the regulators agreed, based on a whole series of pieces of work, that you can actually look at an early change in proteinuria with the therapy, and that gives you a pretty good indication in IgA nephropathy as to whether that drug is going to protect kidney function in the long term. And so the FDA looked at these data, and on the basis of that, they agreed that for rare glomerular diseases, you could look at a change in proteinuria at around 9 months as a reasonably likely surrogate of how that drug is going to protect kidney function in the future. And actually, this could be used for an accelerated approval. And so to date, we have had 3 drugs have an accelerated approval for the treatment of IgA nephropathy in the United States based on proteinuria change at 9 months. And 2 of those drugs have gone on to get a full approval. And so the clinical trial design is now a 2-year study, randomized between a drug and placebo on top of supportive care, with an endpoint at 36 weeks looking at proteinuria change, and an endpoint at 2 years looking at a change in GFR. And so, as I say, we've had 3 drugs now approved on the basis of a change in proteinuria at 36 weeks. And 2 of those trials have now completed, and the 2-year GFR is available. And what those 2 trials have shown is that reduction in proteinuria mapped to a slowing in the rate of loss of kidney function. And therefore, those 2 drugs are now fully approved. So what you will see, certainly in the US, is drugs being approved on a proteinuria basis with early data, and then the trial will continue. And you will then get the GFR data at the end of 2 years when all the patients have completed the study, and that will trigger a full approval for the drug. So we have had an absolute explosion in clinical trial activity and new therapies. And my estimate is we will get 2 new drugs approved to the treatment of IgA nephropathy this year, and we're likely to get 2 new drugs approved every year for the next 3 to 4 years. So having had nothing for 50 years, we're going to have anywhere up to 10 or 12 new therapies in the next few years. So that is how exciting it is, but that also becomes how challenging it is to work out how on earth do we use all these drugs, because it used to be dead easy to treat IgA nephropathy. Put them on a RAS inhibitor to control the blood pressure, and you knew there was nothing else. So you didn't have to think very much. Now we're going to have to think a lot about all of these new therapies and how they fit in and how we might combine them. What's the right first choice for first treatment? What's our backup drug of choice? All those are things we're going to have to think through over the next few years. And so this was a table we produced for a review article a couple of years ago, and it was out of date before the article even got to press. And you can see here the kind of therapies that have been developed for IgA nephropathy. And there are many other mechanisms of action that aren't even on this diagram that are coming through in early phase studies at the moment. And so what I'm going to do is place these new therapies in the context of what we understand is the pathophysiology of this disease. And so if we think about IgA nephropathy is fundamentally an immune complex mediated disease. It's characterized by the formation of circulating immune complexes. These immune complexes are prone to deposit within the glomeruli, where they can trigger inflammation and scarring, and ultimately kidney failure. And the main substrate for that immune complex formation is a particular type of IgA. You'll often see it described as Gd-IgA1 in the papers. Now, Gd-IgA1 is not one form of IgA, it is a collective term for a variety of IgA molecules that all carries changes in the sugars at the IgA1 hinge region. And rather like icing on a cake, these sugars make the IgA molecule very sticky. And so these IgA molecules are prone to stick together. They can stick to other serum proteins, and there are antibodies in the circulation that can recognize those sugar changes, that can amplify immune complexes. And so it's a small excess of this particular type of IgA that is characteristic of IgA nephropathy. And we believe that this particular type of IgA comes from the mucosal immune system. And that's the immune system that lines our respiratory tract, our gastrointestinal tract, and our genitourinary tract. Most of the immunoglobulin, the antibodies you have in your circulation, come from the bone marrow and come from plasma cells sat in the bone marrow. The Gd-IgA1 that we think drives this disease, there's lots of evidence that this is actually derived from plasma cells that are sitting within the mucosal immune system. And actually this type of IgA is completely normal when it is in the mucosal immune system, and when it's secreted into saliva, secreted into gastric juices, because this is a particular type of IgA that is very good at preventing bacteria from entering the body. For some reason, a little bit of it's misdirected into the circulation, and that's where the problems start arising. And of course, this occurs on a genetic background. We're getting a little bit better at understanding that. We've now identified over 30 different genetic risk alleles that contribute to IgA nephropathy. Each contributes a very little amount, which means they're not useful for genetic testing. But we are building a better picture up about the pathogenesis behind the disease based on these genetic studies. And then if we think about what happens when those immune complexes hit the glomeruli, they deposit in the mesangium, and the primary cell that responds is the mesangial cell. And that mesangial cell proliferates. It releases pro-inflammatory and pro-fibrotic mediators. That can lead to recruitment into the glomeruli of inflammatory cells, predominantly monocyte macrophages. And in severe cases, you can have crescent formation. Those inflammatory mediators and pro-fibrotic mediators can cross the glomerular basement membrane, where they can directly impact on podocytes. They can directly impact on tubular epithelial cells, as can the immune complexes themselves. We've got data in a number of studies where we can see these immune complexes cross the GBM and actually directly interact with podocytes and epithelial cells. And that will in turn drive the glomerular sclerosis and tubular interstitial fibrosis. So you can see here what is the impact of those immune complexes accumulating within glomeruli. And all of the features you can see on your screen, we can replicate in the laboratory with cell culture models or animal models. And actually, each of these features corresponds to one of the components of the Oxford classification, because each of these components independently predicts the risk of kidney failure in patients with IgA nephropathy. And of course, all of these processes are amplified by activation of the complement system. So if we think about that background landscape for the pathogenesis of this disease, then we think, where would we want to target? It would make sense, certainly, to think about targeting the disease at the source of the pathogenic IgA. If you switch off the production of this or tone down the production of these Gd-IgA1 molecules, there's going to be less of a drive for immune complex formation, less of a drive for immune complex deposition, less of a drive for inflammation and scarring within the kidneys. And indeed, we certainly have significant evidence to suggest that the mucosal immune system is important. I'm sure we've all seen cases of patients who've had activation of the mucosal immune system, either an upper respiratory tract infection or a GI infection, and within 24 hours they're peeing fresh red blood or Coca-Cola coloured blood, suggesting there's a very clear link between mucosal activation and an exacerbation of the nephritis. Now, we don't understand what that precise link is at the moment, but there is a very clear link between the two. And I mentioned the genome-wide association studies and the genetic studies. And this is really fascinating. So this was one of the first meta-genome-wide association studies we published. And here what we found were a number of genetic risk alleles that their presence increased the likelihood of developing IgA nephropathy. So the question that was asked is, are these just genes that are associated with random biochemical processes in the body, or are they associated with very similar or identical processes and identical biochemical pathways? And then what you can see on the screen here is a pathway analysis, and the most enriched pathway that these genes congregated within was the intestinal immune network for IgA production, really driving home the importance of mucosal IgA production in IgA nephropathy, and in particular the importance of the gut and the intestine in generating that driver for immune complex formation and kidney damage. You could say, okay, let's not touch the mucosal immune system. Let's do what we do in lupus, in ANCA. Let's just hit those antibody secreting cells and just stop them, deplete them, and stop antibody production. And we've tried that. We tried rituximab in IgA nephropathy, and it didn't work. And in fact, it didn't have any impact on Gd-IgA1 or immune complexes, proteinuria, or GFR. But there are other ways to modulate antibody secreting cells. And so something that you're going to see a lot more of, I'm sure, over the next few years are drugs that target these two cytokines, BAFF and APRIL. BAFF and APRIL are two cytokines that drive B cell and plasma cell proliferation, differentiation, and IgA class switch recombination. They're important in the mucosal immune system. They're important in the systemic immune system. And as you can see, they act through different cell surface receptors. And we now have 5 different drugs in various states of development that target either APRIL alone or BAFF and APRIL. And most of those are in phase 3. And I would imagine an anti-APRIL monoclonal antibody will be approved for the treatment of IgA nephropathy at some point this year. So you're going to have to get your heads around prescribing an anti-APRIL to a patient with IgA nephropathy, because realistically that's going to happen within the US, I think, this year. So we can modulate B cells, or we can actually deplete B cells and plasma cells. Now, CD20 depletion didn't work, but actually if you look at what the myeloma doctors do and how they deplete myeloma cells, there are a whole range of other cell surface markers they can look at, and one of those is CD38. And you may all have looked after patients with myeloma who have had daratumumab. Now, daratumumab is not used in IgA nephropathy, but there are 2 other monoclonal antibodies that target CD38 that have been looked at in early phase studies in IgA nephropathy. And so we're starting to see these myeloma type treatments transitioning across, and I wouldn't be surprised if we see phase 3 trials of CD38 depleters starting at some point this year in IgA nephropathy. Now, we could decide actually we're going to leave the immune system alone, or we are going to target the immune system. We want to protect the kidney as well. And that's, of course, what we've done. Really, the mainstay of treatment has been understanding the importance of angiotensin in the renin-angiotensin system and blocking that with RAS inhibitors. But we know that while that slows progression of kidney disease, outcomes are still terrible. So it's not that we can live without it, but we know it's just simply not enough. There's a lot more information now available about endothelin, which does many of the things that angiotensin 2 does, but also potentially other inflammatory and fibrotic effects. And we now have drugs that are capable of blocking endothelin and blocking the renin-angiotensin system. And indeed, the second drug to be approved for the treatment of IgA nephropathy in the US is a drug that combines both a renin and angiotensin receptor blocking action and an endothelin receptor antagonist action. So this is now available in the United States. And an ERA alone that you can use with any RAS inhibitor is likely to be the next drug approved for the treatment of IgA nephropathy. We have SGLT2 inhibitors. They protect against cardiovascular outcomes, against CKD outcomes. Very important to realize these do not cure IgA nephropathy. They will slow the rate of loss of kidney function for all forms of kidney disease. But if you look at what was achieved with an SGLT2 inhibitor in DAPA-CKD or EMPA-KIDNEY, every single one of those IgA patients will still develop kidney failure in their lifetime, even if they're on an SGLT2 inhibitor. So don't think just because you put someone on an SGLT2 inhibitor, you have sorted the problem. You have delayed the inevitable. You haven't sorted the problem because you haven't dealt with the fundamental reason the patient is losing nephrons in the first place. And then we have a whole range of drugs that target the complement system. And we are seeing many, many more of these going into clinical trials. IgA nephropathy has had the most different drugs tested in phase 2 and phase 3. And you can see here each of the proteins that has been targeted with a new drug in IgA nephropathy. And in fact, the third drug approved for the treatment of IgA nephropathy in the States is a complement inhibitor. It targets factor B of the alternative pathway. It is approved on an accelerated basis at the moment. So we have proteinuria change at 9 months, but we don't have any GFR data yet. But that is the third drug that has been approved. So we have a gut-directed therapy, which was the first approved. We have an endothelin receptor and angiotensin receptor antagonist, which was the second approved drug. And the third was a complement inhibitor. And so what's the future approach to treatment going to look like? So where are we going to be in the next 10 years? Well, I think we have well and truly kicked this approach into touch, which is when we make a diagnosis, we start with supportive care with a RAS inhibitor and we slowly build it up. We get them on the maximal dose. We reassess how much proteinuria is, and we have a high proteinuria target before we'll even consider adding another agent. I think we've shown that that simply is not good enough. And if we do that, our patients will inevitably end up on dialysis at some point in the future. What we need to do is what we do in other immune-mediated kidney diseases, and that is hit the disease hard the minute we diagnose the disease and de-escalate treatment as quickly and as safely as we can. So just like we treat lupus, ANCA, we treat the disease hard to begin with an induction regime, and then we tailor off those treatments and get to the lowest possible dose of treatments that keep the disease under as good a control as possible. And that is where we need to move to in IgA nephropathy. And that is what fundamentally we're saying in the update to the KDIGO guidelines. And so what I would want people to start thinking about is you've got your new patient, you've got a diagnosis of IgA nephropathy. The first thing I hope people start thinking of, I want to treat the IgA nephropathy. I want to treat the formation of immune complexes. I want to stop that from happening. I want to stop the damage they're causing in glomeruli. That's how I treat IgA nephropathy. And to do that, I need to reduce the production of pathogenic IgA, because that will stop the immune complexes forming and everything else that then follows. I'm going to want to look to see if I need to also immediately calm down the injury that's happening in the kidneys, just like we do in ANCA and lupus nephritis, where we give a B-cell directed therapy, and then we may or may not give significant doses of systemic steroids or avacopan to calm down that inflammation. That's a short-term measure that is used to treat the here and now. But the fundamentals of managing all of these immune-mediated diseases is to target the production of pathogenic antibodies. And that's where the focus should be in IgA nephropathy, just as it is in membranous, just as it is in ANCA, just as it is in lupus. And of course, we're going to have to accept we must always think about those generic CKD drivers, but that should be our second thought. That should be something we have to do if we really need to. In a perfect world, we would get patients at the beginning of their disease and we wouldn't even need to think about this. But the sad fact of the matter is our patients will come to us late. And so when we have addressed and when we're thinking about addressing those immune-mediated drivers, we're going to have to think simultaneously about those generic drivers of CKD. And of course, if someone has advanced CKD, we must think about cardiovascular risk. So these things are going to need to be addressed simultaneously. But what I hope we move towards is the first thing you think about when you see an immune complex mediated GN that is IgA nephropathy is I want to switch off immune complex formation. That's how I treat this disease. I may need to resort to CKD treatments as well. I prefer not to, I may have to, but actually to treat IgA nephropathy, you treat the disease. And so what do you guys have available to you today? So you have available Nefecon, which is the drug that targets mucosal IgA production in the small intestine. You have systemic steroids. You've always had systemic steroids. We know they're highly toxic and patients don't like them. And cumulatively, toxicity is a real issue, but they're there. We now have iptacopan, which is the factor B inhibitor, which is on an accelerated approval that you could consider using. We also have all the new advances in CKD care. We've always had lifestyle modification. We have RAS inhibitors, we have SGLT2 inhibitors, we have the dual endothelin angiotensin receptor antagonist sparsentan that you have available. And then in grey, you have these groups of drugs that are going to start becoming available over the next few years. And as I say, I think you're going to have 2 new drugs before the end of this year in the United States, and then at least another 2 next year. So this is going to get more and more complex as time goes by, which is great news for patients because it means we've got more treatment options. And I wish I could finish by saying these are the 5 blood and urine tests you need to measure, because that will tell you which of these drugs you need to use when. And it will be really useful because you'll be able to tell whether the patient's responding to these new treatments. Unfortunately, we don't have those biomarkers yet. The best biomarkers we have are proteinuria and serum creatinine or EGFR. It's work that we're doing a lot at the moment to identify biomarkers, but at the moment, I'm afraid we only have proteinuria and GFR, but that hopefully will change over the next decade. So the future is incredibly exciting. And as I say, if I was to give this talk in a couple of months' time, there'd be another drug there. And if I was to give this talk before Christmas, I'd be adding another drug, and so on and so on. And some of these drugs are drugs that you will never have prescribed before in terms of their mechanism of action. So we're going to have to upskill ourselves in how we use these drugs. What are safe combinations to use together? What are the particular things we need to look out for with these new therapies? And how are we going to combine them, and which is the sequencing that we might think about? So I hope you found that interesting. I'm very happy to take any questions, and thank you for listening to me again. And I promise I won't come back for another 2 years. And if you're there in Florida tomorrow, I might be able to see you and say hello. Thank you.
Thank you, Dr. Barratt. Do we have any questions, Valerie?
Nope, there's nothing in the chat. So you can either put your question in the chat or raise your hand. Nothing yet.
Everyone's far too shy and polite.
There's one question. There's one question. And I can, if you can you see it in the chat, Dr. Barratt?
Let me have a look.
Okay, otherwise I can read it to you.
Yeah, so obinutuzumab. So we'd have no data on obinutuzumab in IgA nephropathy. I'm not so sure I would expect it to work because rituximab didn't. And the data in lupus, I have to say, is not as impressive as I imagined it would be. So at the moment, it wouldn't be a drug I would suggest to try. I think we have got data for CD38 depletion, which looks very exciting, and we have data for B-cell modulators, which again is in IgA nephropathy. So it's not a drug I would necessarily go to first off to treat IgA. And I think in terms of the mucosal microenvironment, that is heavily rich in BAFF and APRIL, and those are survival factors, and that's why I think the mucosal microenvironment is resistant to CD20 and depletion strategies with the CD20s. And we know that from the inflammatory bowel disease literature. There's some great studies of people that have had really resistant Crohn's and UC who've had CD20 depletion, and actually they've been rebiopsied and the bowel is still full of plasma cells and CD20 positive cells. So I think it's the microenvironment where these plasma cells are sat that makes them resistant to CD20. So, and I think the Natera test is this is the company that does genetic testing. You cannot make a genetic diagnosis of IgA nephropathy at the moment. The 31 different genetic risk alleles all contribute a very, very small amount of risk. And even when you add them all together, it's not sufficiently precise to allow you to make a diagnosis. So unfortunately, the only way we can do this is with the kidney biopsy. And how about MMF and steroids in East Asian patients? Yeah, it's something where there is data in certainly in Chinese patients that MMF is valuable. And of course, the testing study was almost exclusively in Chinese patients. I think the big challenge with MMF is we've had some studies in Caucasian patients and it's not shown any effect. And was it that those studies just weren't very good and didn't have the right patient population, or there is truly a difference in responsiveness to MMF between Chinese patients and Caucasian patients? So I don't have an answer to the MMF question because we haven't done the right trial to see whether there's truly a race-based response to that treatment. And the steroids, again, I think the steroids, the testing trial showed very clearly, if you give a 6-month course of systemic steroids, the proteinuria goes down, but when you stop the steroids, the proteinuria just comes back up to where it was before. And in the grand scheme of the lifetime of a patient with IgA nephropathy, it's impossible to think you could give repeated 6-month courses of systemic steroids. The beauty, of course, of Nefecon, which is a steroid but is targeted to the gut, is that it's well tolerated, has a much better safety profile than systemic steroids, and therefore you can give repeated cycles. It's acceptable to patients, and the second treatment cycle has as big an effect on proteinuria as the first treatment cycle. So that is where I think we have where there is an advantage over a gut-directed approach versus a systemic approach. And then here, felzartamab. Yep. So to be honest, so felzartamab is a CD38 depleter, as is mezagitamab. Those are the two antibodies that have been looked at in phase 2. You can't get hold of these outside of the trials. So in a couple of patients that I've had that were very high risk, that were doing really badly, I've actually given them daratumumab, and they have done incredibly well. And the reason I've given them daratumumab is our hematologists have the drug in our hospital. So as long as I can find someone to pay for it, then that's a drug you can get your hands on now. None of the other B-cell directed therapies are available, either on compassionate grounds or commercially available to be able to use at the moment. I don't use rituximab. Obinutuzumab, I wouldn't use, to be honest. If I was going to use a drug off label to deplete, I would use daratumumab. So that is something that I've suggested in severe disease in native kidneys, but also severe recurrent disease where there's a real risk of losing a second or a third graft. And we're actually thinking about using it in patients, highly sensitized patients who are coming in for another graft, having lost previous grafts, where we know the risk of recurrence is very high. So it's always something worth thinking about in terms of that very difficult patient that looks like they're going to do very badly, where you've given them everything you can and nothing seems to work. And let's have a look. Combinations. Yeah, combinations are exactly the thing I would love to do. I don't think any of the pharma companies are going to fund a trial. So I think it's going to be left to us to think about how we combine therapies. And I think real world evidence is going to be critical here in terms of, for instance, 2 of the drugs we've got at the moment. What's the impact of being on Nefecon and sparsentan? The trial's never going to happen, but I'm sure there are lots of people in the United States who are on both of those. We need to collect the data and present that data so that we can have an idea about safety, but we can also have an idea about efficacy. For me, I think the way forward is the foundational treatment for IgA nephropathy will be a drug to target the production of immune complexes. The next question I'll ask myself is, do I need to give an anti-inflammatory drug immediately? Because there's so much ongoing damage, I need to get that under control immediately and then taper that drug off once I've got those immune complexes under control. So the combinations there may be a B cell directed therapy and a complement inhibitor, for instance, or one of the new, or potentially another anti-inflammatory, antifibrotic. So that's where I think we're going to start seeing some potential combinations. And then, of course, we use combination therapy to treat CKD all the time, don't we? We have RAS inhibitor, SGLT2 inhibitor, MRA. So those combinations are going to happen separately to the combinations we use to treat the IgA nephropathy. So the IgA C3 ratio, so there's a lot of data from East Asia, from China and from Japan, where the nephrologists there believe that this is a very good prognostic marker. We've looked at it in my laboratory. There have been studies outside of China and Japan, and it has no prognostic significance in European ancestry patients. So again, is this something about the nature of the disease in different parts of the world? And I just don't know the answer to that. I think the only way we really will know is if we have blood samples from all of these different patients in different countries in the same lab who do the same assay, and then we'll know for sure, because every one paper that's published has used a different way to look at IgA C3 ratios. So lots of data in Chinese from China and Japan supporting this. The data I've seen from outside of those countries in non-Chinese patients suggests it's not a useful biomarker, and certainly that's what we found in our UK patients, which again are non-Chinese. So it may well be specific to particular populations. And then urinary CD163. Yep, I think this is a very interesting biomarker. We've seen a lot of data in lupus nephritis and ANCA vasculitis that it's a marker of glomerular inflammation and monocyte macrophage infiltration. We have actually measured it in a number of different clinical trials in IgA nephropathy, and we will present some data in the near future. But it is something that we're working on at the moment. It's not something I would say you can make a clinical decision on at the moment, but it certainly does seem to be increased in IgA and modifiable with some of the new therapies. So what I would say to that is watch this space and see where we are in terms of how that might come out as one of the panel of biomarkers that we might use going forwards to look at monitoring treatment response. And here we go. What makes up complexes? Okay, so that's again a great question. And if you had the misfortune of seeing me last year at the ASN, I gave a whole talk on this because we're now at the point of being able to purify immune complexes and actually, using mass spectrometry, work out all the protein constituents within those complexes. And it is surprising how many different proteins are within these complexes. And many of these proteins have significant biological functions. So one of the hypotheses that we're playing around with at the moment is that actually the IgA and the IgG form the complex, the lattice, which collects proteins as it circulates through the bloodstream. But actually the IgA and the IgG are not that damaging to the glomerulus. It's all the proteins that they're bringing with them that actually cause the inflammation and scarring within the kidney tissue. Because one of the things that's always been difficult to understand is, and if you've been to kidney biopsy meetings, is the amount of IgA immunofluorescence, the amount of IgA you can see in a kidney has no relationship to the risk of kidney failure in the future. So we're not necessarily measuring the right thing that's in those deposits that will give us an idea about how much inflammation or how much damage there's going to be. And one of the studies we did with Nefficon in their phase 2 study was we measured the amount of IgA, IgG complexes, and we showed that treatment of the gut reduced circulating immune complexes. But then we performed mass spectrometry on the purified immune complexes, and we found that for the very first time that Nefficon, a drug, was able to alter the types of proteins within those complexes. And when you look at what those proteins do, those proteins that were reduced were associated with inflammation and scarring. So I think we're going to find a lot more out about this, rather like the story with membranous, where it was possible to laser capture glomeruli and then work out what the antigens were there, we can collect these immune complexes and work out what proteins are there and link those proteins to a risk of kidney failure, to a response to a particular drug. So I think, again, there's going to be a lot more data come out about this. And we've got a big study which we're just analysing where we've looked at immune complexes in IgA nephropathy patients compared to IgA vasculitis patients with relapses and remissions to see whether the kind of phenotype of IgA nephropathy versus IgA vasculitis is due to the proteins in those complexes, and whether the proteins in the complex change when you're having a relapse and whether you're in remission. So, all I would say is watch this space, because we're going to be seeing a lot more data around immune complex composition in IgA nephropathy and IgA vasculitis. And then we've got, is there a utility in combination treatment with Nefecon and a complement inhibitor? I absolutely think they target predominantly different pathways. We know that there is some systemic absorption of budesonide, so it will have a direct steroid-like effect on the kidney tissue itself. But if I had someone with significant inflammation where I wanted to control the pathogenic IgA and get on top of inflammation as quickly as possible, I would see no reason why not to combine those two therapies. I think that's exactly what the paradigm is showing us. I have zero data on safety and efficacy, but that's where your experience, because you are the only country that has access to iptacopan at the moment, because it's not approved anywhere else, that's where we can start getting data and getting an understanding of how we put these drugs together. But I do think that is an obvious choice in someone with a very inflamed kidney biopsy, where you want to get on top of immune complexes and give an anti-inflammatory to have an immediate effect. Right, it was like London buses, we say. Nothing happens for a while and then it all turns up at once. So no questions, and then everyone asks questions at the same time.
Are there any other questions from the participants?
So can I just say, great questions, and please, if you ever bump into me, please come and say hello.
There's one more question.
One more.
Okay, so is it
Got
safe
one
to stop iptacopan? So certainly in IgA nephropathy, I would have no problem stopping iptacopan. I think you need to, and I certainly, how I think about iptacopan is it is a induction therapy that I will taper down and stop once I've got control of the immune complexes. So I don't think there's any risk you're going to get a flare of disease as long as you have controlled the immune complexes. If it's iptacopan monotherapy, then I would just imagine the disease will just come back in exactly the same way when you stop it, because you've not fundamentally altered the disease. You've just stopped inflammation. So I don't worry about like PNH, where you will have a potential massive hemolysis when you release complement inhibition. I don't think that's going to happen in IgA nephropathy. So I think it is absolutely safe to stop.
Dr. Barratt, thank you so much. I appreciate the presentation, and you got a lot of questions, so thank you. I thank the audience for joining us tonight. And Dr. Barratt, I will see you tomorrow in Orlando.
Yeah. Thank you very much, everyone, and have a great day. Bye-bye.
Safe travels. Bye-bye.
Thank you. Joanna, I just wanted to follow up with you in case there's anything else you needed from on behalf of Fraser and so forth.
No. Is everybody off?
Oh, just 3 more people.
Okay.
I wanted to catch you before you left.
Oh, no, I'm actually going to stay on a little bit until all the participants have.
I'll stay.
Yeah.
Oh, yes, the recording will be available. I'm not quite sure what the time frame is, but it will be available. That reminds me to stop recording now.